Welcome to the Virtual International Speaker Program. I welcome all the faculty and delegates on the behalf of Manage Health Foundation. Now, I request Dr. Kirtana from AstraZeneca to invite and introduce our program directors. Over to you.
Yes, thank you, Anshika. Thank you so much. And a very good evening to everybody. So it gives me great pleasure on behalf of my team to invite you all to this early lung symposium, which is a virtual international speaker program. It's an integrating immunotherapies in early lung cancer management. And we have Dr. Amit Rautan, sir, who's the HOD and consultant in Manipal Hospital, Bengaluru, who will be joining us today in another 5 to 10 minutes. And unfortunately, due to some personal emergency, Dr. Arvind Kumar, sir, couldn't join us today. So let's go on to the next session. Our first session will be the debate session. Yes, can you just share that slide, please? Yes. So, the debate topic for today is management of stage 3 N2 multi-station disease, perioperative immunotherapy with surgery or chemoradiation followed by immunotherapy. So we have Dr. Bhushan Thombre, sir, who's a senior consultant in Inder Prasad Apollo Hospital, Delhi, and we also have Dr. Sajan Raj Purohit, sir, who's a senior director of BLK Max Super Specialty Hospital, New Delhi. Over to you, sir.
Yeah, welcome. Thank you to this AstraZeneca symposium on management of lung cancer. Today's focus, my focus will be management of stage 3 and 2 multi-station nodal disease, perioperative immunotherapy with surgery. So, can you show?
Yes, sir. I'll share the slide from my side. Just one second.
Yeah. Full screen. Can you make it full screen? Yeah. So next slide. As we all know, up till now we are following AJCC 8th lung cancer staging. Now the 9th AJCC is on the way. Stage 3 N2 disease, you can see from the yellow highlighted mark where why people fear about N2 disease. N2 disease is a heterogeneous group of disease where, and in that if it is a multi-station N2 disease, it has a negative prognostic value, and it is associated with poor outcome. And you can see from various studies, N2 disease single station, the 5-year survival is 23 to 43%. When it comes to multi-station N2 disease, it drops down to less than 17%. Next slide. So you can see the N2 NSCLC, where some people have categorized into N2A1, N2A. N2A1 they have made into single zone, non-bulky lymph node spread, no skip metastasis. So N1 nodes are not there. And N2A2 single zone, non-bulky lymph nodes spread with skip metastasis. Some N1 nodes are also involved. And N2B, where multi-zones, say about for on the right side, level 2, level 4, or level 6, all the three are involved. On the left side, level 5, level 6, and level 7 are also involved. It is like multi-station N2 disease. Next. The simple algorithm, when you do radiological assessment, PET scan, and all the patients with suspected stage 3 NSCLC history physical examination, and when the metastatic disease is ruled out, PET scan and brain imaging, and a curative intent of treatment is planned for those candidates who look fit a pathological assessment of the mediastinal nodes either by EBUS or mediastinal invasive staging by mediastinoscopy is undertaken. And once the patient is confirmed or suspected, stage 3 NSCLC, a MDT is undertaken. An MDT, the crucial role is of a surgeon who determines the resectability of the present situation. If a tumor is resectable, he will label it resectable, and whether it is operable or not operable, that we will assess after the new adjuvant treatment. Next. So before the era of chemo IO, the flow chart is like patient comes, diagnosis, staging is done, MDT is undertaken. If it is a resectable disease and N2 disease, then neoadjuvant chemotherapy or RT is given, surgery is contemplated, pathological staging is done, and depending on the pathological specimen, the node status, adjuvant therapy or no adjuvant treatment is given. But in the era of chemoimmunotherapy, next slide, the same, after once it is deemed resectable, it is replaced by the new adjuvant chemoimmunotherapy, and then the patients are reassessed for operability, their physical fitness, cardiovascular performance status, and all, and then he undergoes surgery, pathological restaging. Then we have a variety of options from adjuvant chemotherapy to continuing immunotherapy to no adjuvant treatment to surveillance. What is the aim of overall treatment? Next slide. The aim of overall treatment is to prevent recurrence, achieve complete cure or remission, a disease-free survival. So how can we know that the disease is cured? Either to determine radiologically, follow-up imaging, PET-CT, CT scans, or examination of the specimen if operated after neoadjuvant therapies like post-surgery, and then follow-up imaging. And other tests coupled with maybe in future liquid biopsies will come up where we will come to know about CTC and ctDNA. The values will tell us whether the disease is under remission or it has recurred. Next. So surgery after neoadjuvant chemoimmunotherapy is challenging. It is safe and feasible. Even though it is challenging, it is still doable. Although some level of surgical expertise is required to contemplate it safely. The optimal timing of surgery after neoadjuvant therapy is not yet standardized. Various papers are available. You can see pulmonary resection after immunotherapy. Various people have published challenges. Even the sleeve lobectomies, the number of sleeve lobectomies have increased after neoadjuvant chemoimmunotherapy. Next. So this is a variety of pictures showing different challenges after surgery. During the surgery after chemoimmunotherapy, I think so. The next speaker is going to speak for this. We will skip this slide. Next slide. Next. So now we will come to the main point. What data or the evidence we have in supporting that neoadjuvant chemoimmunotherapy followed by surgery for multi-station entities? Now we have the Asian trial where the now subgroup analysis have come, where perioperative durvalumab has been given to the patients with resectable NSCLC with and baseline N2 lymph node involvement. And the second thing is CheckMate 7070 study from the phase 3 studies, where perioperative nivolumab by the nodal status among the patients with stage 3 resectable NSCLC. So in the word resectable is very important in both these studies, where we consider neoadjuvant protocol in chemoimmunotherapy in stage 3 N2 disease. Next. Coming to Asian study, the study population, the numbers were 802, and the population were resectable NSCLC stage 2A to 3B, but our debate is concerned with N2 disease. Lobectomy, sleeve resection, or bilobectomy were planned as per surgery. There is a durvalumab arm and there is a placebo arm. Durvalumab arm, they have received 4 cycles of durvalumab, 1,500 milligram IV, and then surgery is contemplated, and thereafter 12 cycles of durvalumab has been given, and placebo intravenous is again 12 cycles have been the primary endpoints. very important, pathological complete response, and EFS has been event-free survival in the neoadjuvant setting has been studied, and the key secondary endpoints are major pathological response and disease-free survival. So we will come to the graphs in the next slide. So baseline characteristics in N2 subgroup and a modified intention to treat population, we have 740 patients, where 49.5% with baseline N2 nodal status. They had this baseline N2 nodal status. Age group, we in the durvalumab, and both our median age group was like greater than or equal to 70 to 75 years. Male predominance, smoker predominance, ECOG performance scale 0. The Asians and the whites were predominant. The disease stage 3A and 3B are almost equal, 51% to 48%. Histologically, squamous and non-squamous, squamous were 45% and non-squamous 54%. Lymph node station involvement, N2 multi-station patients were 18% in the durvalumab arm and 21% in the placebo arm. Planned neoadjuvant platinum agent, the preferred agent was carboplatin in both durvalumab and the placebo arm. The next. So the procedures were open procedures and minimal invasive procedures in the durvalumab baseline N2 arm is almost the same, 67 patients and 71 patients. Lobectomy was the most common operation done along the trial. Pneumonectomy were 13% in the durvalumab arm, and the MITT population it was 27 patients. The patients with surgical delay there is was in 28 patients in durvalumab arm, whereas in placebo arm it was more 34 patients, 23.6%. Reason for surgical delay, it was unresolved toxicity of neoadjuvant treatment. It is almost same in the see in durvalumab arm, placebo arm, whatever. Next. Why we are focusing on this treatment regimen is this slide. The pathological complete response and the major pathological response. What separates the placebo from durvalumab in the perioperative setting is you can see from the blue graphs on the left side versus the orange graphs. There is a significant difference. You can see 11.7% in both the groups. Durvalumab arm, it is like 16.6%, 16.6 in pathological complete response. If you see the N2 multi-station group, it is 3.8% pathological complete response. And when we see the major pathological response, the perioperative durvalumab arm excels in both the setting. N2 multi-station disease, it is 1.8%. Next. So event-free survival. So there is a event free survival in both the single station and multi-station group. You can see the difference in the two graphs. At 12 months, it is 72.9% for the durvalumab arm and 62.6% for the placebo arm. And at the 24 months, it is like 66% in the durvalumab arm and 43.7% in the placebo arm. And the MITT also, the similar differences in the graph is present. Next, coming to Checkmate 7070. Again, a second study where stage 3B N2 NSCLC, no prior systemic anti-cancer treatment, ECOG, no EGFR or ALK mutations. Some patients equal 1:1 received nivolumab 360 mg, three weekly doses, 4 cycles, and placebo, then followed by radiologic restaging, assessing, and underwent surgery within 6 weeks post neoadjuvant treatment, and thereafter nivolumab 480 mg 13 cycles, and placebo or drug for 13 cycles. Here, the primary endpoints were EFS, event-free survival. Secondary endpoints were again the pathological complete response, major pathological response, overall survival, safety, and exploratory analysis, clinical outcomes by clinical stage N2 or non-N2 nodal status. We come to the second slide. You can see the significant difference in the graphs in the multi-station group. The patients with resection, those who are undergoing receiving the perioperative nivolumab, 37.5% pathological complete response compared to the placebo 3.4% population. And all patients taken together, it is like 29% in nivolumab and 22.7% in the placebo group. Next. So, event-free survival from definitive surgery, you can see the separation of the graphs in both the survival curves in stage 3 and 2 multi-station disease, where it is in the nivolumab arm is 18.2, and the placebo group is like 4.7 to 16.5. And at the 24 months of surgery, still the nivolumab is majority are above 60%, while the placebo group are less than 40%. So what does NCCN guidelines say about stage multi-station N2 disease? Next slide. So again, the N2 nodes, either the definitive or concurrent chemoradiation or systemic therapy, no apparent progression, then surgery,
So
then
I
adjuvant
think
systemic
your
therapy.
time's
Yeah.
up.
Yes. Yeah.
We have
Okay.
to.
Yes. Next. Finished. There is another paper which summarizes all the available treatment protocols for as a neoadjuvant setting in stage 3 lung cancer. Next, the ASCO update 2024. We have the whole flowchart with all the armamentarium, the neoadjuvant chemoimmunotherapy, neoadjuvant chemotherapy, neoadjuvant concurrent chemoradiotherapy, everything in the place, whatever you can choose on it. Next. I can show a visible example. We had a 66-year gentleman, adenosine right lung upper lobe, stage 3B and 2 disease, EGFR negative, PD-L1 9%. He received 3 cycles neoadjuvant chemo-IO, single port VATS right upper lobectomy, mediastinal nodal dissection, and histopathology was pathological complete response. Next slide. This is the arrows. You can see 95% necrosis, percentage of residual viable tumor 0%, and the staging after surgical resection is T0, N0. And the next slide. So I am a supporter of perioperative immunotherapy with surgery in stage 3 and 2 multi-station disease. Why? Perioperative chemoimmunotherapy takes care of micrometastasis. The treatment assessment response is done with the surgical specimen. Pathological staging is available, and surgery is safe and feasible. Even the minimal invasive options like VATS and RATs are available. Disease portion is removed completely, no confusion in follow-up surveillance over immune flare and tumor recurrence. Neoadjuvant treatment regimens potentially improve the benefit of curative surgery in well-selected patients with locally advanced NSCLC. And you can see from the previous AGN and Checkmate 77, event-free survival, and also the PCR and MPR rates. The perioperative immunotherapy has a major role in the PCR and MPR rates of this. So I will like to hand over this debate to Dr. Sajjan Rajpurohit, who will take us to the another option for stage 3 multi-station N2 disease. Thank you.
Thank you so much, sir.
Am I audible and visible?
Yes, sir.
Okay. Thank you, organizers, and thank you, Dr. Bhushan, for such lovely presentation. So, two key takeaways from your presentation, which I could get was surgeon is very important. Surgeon has to be selective, and the kind of N2 which we say N2 is to be chosen wisely. And all the data which you showed where there was a lot of difference, that was very small number of patients. So such data, which is not a planned subset analysis, is not of real good use to the scientific community. And that's why still category 1 is chemoradiation, especially in a bulky N2 or a multi-session N2 disease. So patient selection remains very important. Now I will come to why we should choose a standard of care as of now, and why we are not still ready to switch over to perioperative IO followed by surgery for most of our patients. So now if we just see, we have this has been already discussed, that obviously it's a multidisciplinary team management. We require pathologists, radiation oncologists, medical pulmonologist, thoracic surgeon. We decide we decide what kind of an exact staging, clinico-radiological staging the patient has. Sometimes we require EBUS, we require mediastinoscopy to exactly define what kind of a disease it is. So now, as of now, if we just go to stage 3 unresectable category, where the surgeon feels that he will not be doing justice to the patient by going for upfront surgery, that is where we have the role of concurrent chemoradiation, and it has been amply shown that concurrent chemoradiation is better than sequential chemoradiation. So this remains the standard of care, and as of now, if you ask among all our panelists or the people in audience, people will choose chemoradiation as their preferred choice. Next slide. Can we go to next slide, please? So this was based upon this large randomized Pacific 3 data, double-blinded placebo-controlled multicentric study, which showed that let's incorporate it after operative kind of approach. Next slide. And if we just go to the specific data, next slide. So you just see it has got a large follow-up now of more than 5 years, and we can find that patients who were given chemoradiation along with the adjuvant durvalumab continued to almost 42.9% patients were surviving even at 5 years of follow-up, and this was significantly higher than the patients who were only exposed to chemoradiation. Next slide. Next slide. With respect to PFS, if we compare PFS, you can still see the PFS was almost double at 5 years. It was 33.1% versus 19.1% and 19% at 5 years. So durvalumab, the median OS was 16.9 months in the durvalumab arm compared to the placebo, which was only 5.6 months. There was more than tripling of the overall survival in the durvalumab arm compared to the standard chemoradiation arm. Now, next slide. So, based upon this landmark trial, durvalumab is the first approved IO in this setting. And if we just see the safety profile, both the arms were well managed for safety. That there were no new safety concerns. The only issue which was that some people had higher degree of radiation pneumonitis that was compared to the placebo arm, significantly around 5% of the patients. Next slide. So now if we just see the post-hoc analysis of N2 disease. So if you compare N2, the PFS, there was, if we just saw the graphs there, if you see the graphs here, there's again a clear separation of curves. And if you just see the number of patients here, so if you see in the N2 disease, the durvalumab versus placebo, there was a clear separation of curves. And even at 18 months, the PFS was more than double, 26% versus 50.6%. And also, the OS continued to be at 2 years at more than 68.3%, which was much higher than the 51.1% in the chemo radiation arm. Next slide. Now coming to the real world data from Pacific. So if we just see the data collected through various multi-centers in the real world, the median follow-up was 38.7 months. And again, the primary endpoints were PFS and OS. Next slide. Next slide. The real world data matches both in the OS as well as in PFS with the Pacific data. So even in the real world, the 3-year OS was 63.2% and the PFS was 42.2%. Next slide. So CTRT followed by durvalumab actually improved. There was an absolute improvement of 11.3 months in the PFS. There was a 32-point reduction in the overall risk of death, and discontinuation rates were very low. So only 15% patients had discontinuation of durvalumab, and 6.3% did due to pneumonitis. So less than 10% of patients actually had a significant side effect, which led them to have discontinuation. And if you just see the difference of OS, the OS was only 29.1 months in the placebo arm compared to 47.5 months. So this has become the standard of care for multi-station bulky end-to disease, upfront unresectable. Such overall survival as well as PFS were never seen before in the last 2 decades. Next slide. Next slide. Now, no, just go back. So the first thing is, as Dr. Bhushan had told, that sometime there are 2 issues with perioperative approach. Number one is that sometimes really surgery can be more challenging in such patients because of the already existing end-to disease. The other one is sometimes patients drop out and they do not undergo surgery. In fact, in all the 3 studies, you can find that the number of people who dropped out was in the tune of around 20 to 24%. So almost 1/5 of the patient did not undergo surgery. So that was one concern with this perioperative approach. Next slide. All the important trials had drop off for around 1 in 5 patients not undergoing surgery. So if you just see here, not all patients were able to achieve pathological complete response. If you just see the end-to disease, the pathological complete responses were in the agent studies were less than 4.3%. Whereas I'm very surprised how in your this trial, one of the trials he showed that pathological complete response were 35%. I was not able to understand because how overall intention treat population had less pathological complete responses when compared to the end-to disease. So I can't understand. I will have a answer from Dr. Bhushan how end-to disease could have higher pathological complete responses, which I fail to understand. Next slide. Also, there's no OS data which is available with us. So we now know there's a significant improvement in the OS, and which is the absolute marker of benefit of a therapy. So with all these trials, though they appear promising, but I feel that they will help in best in resectable resectable lung cancer rather than unresectable or bulky end-to disease. So I still feel that this data is not mature enough for OS and also for adoption, especially in this subset of patients where I still feel that these patients will benefit more with definitive chemoradiation when followed by immunotherapy. Next slide. So to conclude, chemotherapy followed by chemoradiation followed by durvalumab is the most appropriate, I would say, as of now, standard of care for stage 3 end-to disease. The era of immune checkpoint inhibitors prospective clinical studies comparing surgical and non-surgical studies are warranted because we don't have a clear-cut head-to-head comparison between CTRT versus perioperative immunotherapy followed by durvalumab. by surgery. If that kind of a trial is there, then we'll find an answer to the right way to approach such patients. And patients who are potentially operable. Furthermore, improved and uniform definition of patient who may be suitable for surgery actually is essential. It's the multidisciplinary team which should decide whether this patient will really be a good candidate for surgery. And surgeons sometimes have difficult choices, or they sometimes make. In fact, I will not shy away, but then sometimes they make poor surgical choices where they think that patient will be resectable and that turns out to be unresectable. So such patients require a MDT where all these important stakeholders decide, and then they decide which is the best approach for them. So in my opinion, patients who are resectable at upfront this thing, I think I will agree with Dr. Bhushan that a perioperative immunotherapy followed by surgery might be a good choice. It might help you choose better patients. It might help you downstage your disease and make better surgical decisions. And that is why we have moved towards, in majority of cancers, be it breast, be it esophagus, be it stomach. So definitely I'm all in for resectable disease. We try to make it much more contained, have better selection of patients into the surgical cases, and there is where I would stand for a perioperative IO plus chemo followed by surgery. But for an unresectable disease, I still feel that chemo radiation followed by adjuvant IO might be a better choice. Still, we have a head-to-head comparison of this approach being compared to a perioperative followed by surgery approach. That will be convincing. So with this, I rest my case and back to the organizers.
Thank you. Thank you, Dr. Sajjan. Thank you, Dr. Bhushan. Both of you have made very pertinent points in the debate. We clearly get these are two different approaches. N2 is always a very tricky decision. The clear operable ones are clearly everyone is moving towards neoadjuvant IO followed by surgery. The unresectable ones, CTRT is still standard. This N2 is an individualized decision, and both of you have made this point very, very clear. I think we won't get time for taking up a further rebuttal because we are running short of time. We are running very late. Let's move forward, and we'll take up these questions as they keep coming in. We'll move forward now. The next talk is going to be Dr. Manish Singhal, who is the senior consultant medical oncologist from Indraprasth Apollo Hospital, Delhi, and his talk will be on role of pathological response in early lung cancer. Over to you, Dr. Manish.
Hi, Amit. How are you?
Have you?
So I'll request somebody to share the slide set. So my subject is more like a concept building of role of pathological response in early lung cancer. And this is coming from the various clinical trials which have been done, some of them having the primary endpoint as pathological CR or a MPR, and some of them having this endpoint as a secondary endpoint. And we have not really reached the time point where we use these endpoints as we use them in breast cancer, but I think we are getting there. And this is all happening because of the IO, immuno-oncology drugs. So going forward from here, and of course there are benefits of using neoadjuvant therapy. And once we are likely to hit something that we are hitting in breast cancer, by the virtue of using either IO or some other strategies, I'm sure that pathological response will become so very important as we now do it in even early stage breast cancer. Next slide, please. So there are different parts to it. So the guidelines are quite well defined as far as we use it in breast cancer. So what defines a pathological CR and what defines a major pathological CR in major pathological response in breast cancer in lung cancer. So this is about acquiring the specimen and processing the specimen very strictly. Next slide. So there has to be an optimal tissue journey, and as I said that there has been a lot of studies which has shown the DFS and the EFS being improved, and the OS data is maturing still. But we do have robust data as far as early stage lung cancer is being treated now with neoadjuvant immuno-oncology drugs with chemotherapy. Next slide, please. So of course, selection of patient is very important in all stages. For a very early stage, perhaps it may be too early to say that we got to go the neoadjuvant way. But for any stage which is stage 2 or maybe 1B and above, up till stage 3A, deserves a neoadjuvant therapy because there is definitely some survival benefit or DFS benefits which are coming through. Next slide. So, so in resectable, of course, we know that the standard of care has been either surgery followed by adjuvant chemotherapy or a neoadjuvant chemotherapy, but there has not been major difference between using the same chemotherapy in the neoadjuvant setting versus the adjuvant setting. And similarly, we don't really have any data of using the same chemotherapy in the or chemoimmunotherapy in the neoadjuvant versus the adjuvant setting. But the neoadjuvant therapy usage can help in increasing pathological CR rates as well as MPR rates, and this can correlate to survivals. So you can select your patients well. Perhaps in times to come, we will have something to give or offer patients who do not achieve these endpoints. Next slide. So potentials and benefits of using any neoadjuvant therapies, you can downstage the disease so that a lesser surgery is done. It may improve overall survival. It may eliminate the micrometastasis, may reduce the recurrence risk. Patient may be better or fitter to receive chemotherapy in the neoadjuvant phase, as some of them can become sick enough or not fit enough to receive chemotherapy after the surgery. And of course, improve tolerability of adjuvant chemotherapy, of neoadjuvant over the adjuvant chemotherapy. And of course, pathological responses can guide further therapies as we do in breast cancer. Next slide. Next slide. So these are early endpoints. And of course, we don't have hardcore data in non-small cell lung cancer to guide therapies based on PCR and MPR. These are early days for making these endpoints or pathological endpoints as robust markers, but we need more approvals. We need more FDA and EMA approvals on it, and we are moving towards that. Next slide. So just quick recapitulation of what PCR means. Of course, PCR is, we all understand that there's no viable tumor left, and MPR is less than 10% viable tumor left, which correlates with improved DFS. Next slide. So this is about the recommendations from ISLC, that how do we need to process the sample, the histological assessment, and what determines the response. Next slide. And this is about the regulatory approvals which require further evidence to support PCR and MPR as early endpoints. So work is going on in this particular regard. Next slide. So these are various studies which have been done, and as you can see, some of these studies did have PCR as their primary endpoint, whereas some of these studies had PCR or MPR as their secondary endpoint. And many of these studies we are already well versed with, which other speakers have alluded. Next slide. So from two perspectives, clinical practice standpoint and from the clinical trial standpoints, so both are important. So we know that clinical trials will set in and give us guidance about the clinical practice as well. And so neoadjuvant trials are routinely reporting standard outcomes based on PCR and MPR rates, and they are trying to correlate this with overall survival, disease-free or event-free survival at 5 years endpoint. And these are getting incorporated into standardized protocols, so as for daily practice you can use this as clinical practice guidelines. And of course, there's some artificial intelligence which is being used, and digital imaging to automate tissue assessment so that the human error can be nullified. Next slide. So to conclude, PCR, MPR can be used to assess treatment outcomes much more rapidly. Otherwise, the adjuvant therapies can take long times to deliver the results. So these can become possible surrogate markers of overall survival and disease-free survival and event-free survival. And there are authorities which are working on updating the definition of PCR and MPR, plus the recommendation on how to process the resected lung tumor. Standardization of lung tissue assessment and validation relationship with PCR, MPR, and long-term survivors are likely to facilitate the clinical implementation of these endpoints in daily practice. And ongoing phase 3 trials in resected early stage non-small cell lung cancers are using PCR and MPR as primary and secondary endpoints. And this is likely to expedite treatment advancements in early stage non-small cell lung cancer. Thank you.
Thank you, Dr. Manish. Thank you for that clarity on the PCR and the MPR, and this has become very important for all of us now in trying to understand when we do neoadjuvant therapy, what response we get and take further decisions. So thank you very much. I think now we'll move forward because now we have a international expert here. It would be a pleasure to welcome Dr. Jonathan Spicer. He is an associate professor of surgery at McGill University, where he is the medical director of the McGill University Health Center Thoracic Oncology Network. He chairs the McGill Regional Thoracic Oncology Tumor Board and is co-director of the MUHC Thoracic Oncology Clinical Trials Unit. He is one of the PIs and the authors for the AGENE study, and as well as multiple other perioperative studies. It will be a pleasure to listen to Dr. Jonathan Spicer about the early stage management and how we are integrating immunotherapy into the management. And I think this will be a good opportunity to put up all the questions also what everyone has in this exciting field. So we welcome you, Dr. Jonathan Spicer.
Okay, thank you very much. Can you guys see my screen and hear me okay?
Yes, that's fine.
Okay, great. Thank you for the kind introduction. So let me just make this a bit smaller. Okay. Oops. All right, we'll get right to it. These are my disclosures. Just as a point of slight correction, I wasn't actually on the AGENE trial, but I was on a number of the other ones. But you'll get my point that they're all quite similar as we go through this talk. So some of the key things I wanted to cover in the next 30 minutes or so. I'll go through a brief landscape of resectable non-small cell lung cancer, at least the systemic treatment evolutions. I see that you guys have already discussed many of them, so I'll be quite brief there. I want to talk a little bit about the importance of overall survival and health-related quality of life as key outcomes in the early stage lung cancer space. I'll have a brief discussion of what I consider when I think about the term resectability. We'll go through a few of the key subgroup considerations, and some of them will go quickly because, again, I see you just had a debate about multi-station N2. So maybe we'll move. You'll just hear my personal views on that, and then we'll move through the data quickly. We'll talk about the other subgroups such as PD-L1, the importance of stage, the importance of percent residual volume of tumor. There's a great talk here on pathologic response, and I'll show you some of the key data on that subject in a moment. And if we have time, I'll talk about ctDNA dynamics as well. Briefly touch on the hot debate of whether to be considering just pure neoadjuvant regimens versus perioperative, and then some of the real world data that we have here from Montreal from two large centers, our own and the University of Montreal, which is just down the road from us. Oh, there's some okay, yeah, if there's too much noise, let me know, but there's a bit of construction going on in my home right now, so hopefully it's not too bothersome. So this is this table that we've had now growing almost every few months as new trials become published and more results are released. And we have an abundance of data in the resectable space that are all phase 3 data. And I know you had a compelling talk about the concurrent chemoradiation space. So that's one trial here. There's 8 or so, most of which are supporting the use of immunotherapy around surgical resection. The latest updates are those from the BR31 trial. Oops. Which unfortunately was negative. And maybe if there are questions, we can talk about that in a little bit more detail. Keynote 671, which recently published its overall survival data, as well as the health-related quality of life, and I'll touch on those data briefly. And so those are the main recent developments from World Lung and ESMO. If we consider the US and European approval landscapes, we have Checkmate 816, which is both FDA and EMA approved. The exception in the context of Europe is that they've excluded patients with PD-L1 negative tumors. The approval in US and Canada is across all PD-L1 strata, and I'll explain to you why we think that's the correct approval. And then in terms of adjuvant therapies, there's both the Empower 010 regimen and the Keynote 091. Key differences between these two regimens are that Keynote 091 is across all PD-L1 strata, whereas for Empower 010, it's for PD-L1 greater than 1%. And it's worth mentioning that in Canada, Europe, and many other jurisdictions, it's only for the greater than 50%, and I'll show some data as to why that is. In terms of the perioperative regimens, we have AGN, Keynote 671, and just, I think, yesterday or the day before, the FDA approved Checkmate 77T. Now many regimens approved in the US for perioperative therapy. So overall survival and quality of life, I would say these are our primary objectives. This is what our patients care most about. They want to live longer, but they want to live longer with better and more durable and preserved quality of life. So these are key focuses when we're talking about the early stage space. So why is there a discrepancy in terms of the approval for adjuvant immunotherapy in the Empower 010 trial? Well, it's because almost all of the benefit is driven by the PD-L1 50% or greater patients. In the PD-L1 less than 50, 1 to 49, the hazard ratio is pretty close to 1. And interestingly, in the PD-L1 negative patients, the hazard ratio is actually on the other side of unity, suggesting that there may be harm. And I think that's very, very important to think about when we're considering perioperative regimens, is to think about what is the potential harm we can cause by offering patients excessive or unnecessary exposure to checkpoint inhibition. This is not overall survival data, but it is the BR31 trial data that was a Canadian-led effort out of the Canadian Cancer Trials Group that was presented by Dr. Glenn Goss at ESMO. And the reason I show it here is that it is the largest trial in the adjuvant space with 1,400 patients or so randomized. And it's definitively negative for disease-free survival. Now, there may be some thoughts about, with the PD-L1 level or whatever, but when we looked at all of the subgroups, there was really no group that benefited. Some people argue that maybe the surgical cohort with placebo overperformed, but what is clear from the adjuvant space is that the results are much less consistent from one study to another, where we have some studies showing activity across PD-L1, such as the Pembro 091 trial, other studies like 010, which is only in the greater than 50%, that we really see significant activity, and the BR31, where across PD-L1 strata there is none. And so these inconsistencies make us wonder, what is really the value of adjuvant immunotherapy, and the fact that we haven't really identified the key subgroups that benefit. On the other hand, if we do a meta-analysis, which we published in the spring in JAMA Oncology, of the neoadjuvant and perioperative trials, they are consistent in terms of demonstrating a benefit, and not just an event-free survival benefit, but an overall survival benefit. The hazard ratio here is 0.6 to 5 or so, and it's clearly statistically significant. Of course, we have 671, which on its own is statistically significant for overall survival. So I think any claim that says that neoadjuvant or perioperative therapy doesn't offer overall survival benefit would be false. It is a very significant, in fact, the most significant impact of immunotherapy in the early stage lung cancer space to date. Some people have questioned whether the control group is the correct control group, the neoadjuvant chemo followed by surgery. Most people around the world were treating patients with stage 2 or 3 disease with upfront surgery as the standard, and then offering adjuvant chemo. And that's part of the reason why the adjuvant studies were designed as they were. This is unpublished data that one of my fellows put together, where we've done overall survival KM curve reconstructions using publicly available data. And what you can see is that the red line is patients from the ISLC staging database, the pathological staging database. So these are patients who have had surgery and then went on to whatever the standard of care would have been for wherever those patients were recruited into that database. And you can see that the majority of the patients on that red line are actually stage 2 patients. 55% are stage 2. And that curve is completely overlapping with the meta-analysis or the sum of all the control groups from the neoadjuvant and perioperative trials, which is Checkmate 816, Keynote 671, AGN, 77T, etc. All the trials that have submitted overall survival data. And in this case, the vast majority of the patients are in fact stage 3. So they are more advanced in stage, and they have equivalent survival to the upfront surgery patients who are predominantly stage 2. And what's clearly ahead of all of them are the patients who got neoadjuvant chemoimmunotherapy. So any claim that the control group from those trials was inappropriate isn't really supported by contemporary real-world data, and really further supports the notion that neoadjuvant immunotherapy administration is the preferred approach. What other overall survival data do we have if we get into the specifics? So we have data from Checkmate 816, which I was fortunate to present at ASCO. These are the most mature data for the neoadjuvant space with 4 years of median survival. And we have a hazard ratio that remains strongly in favor of the receipt of neoadjuvant nivolumab, hazard ratio of 0.71. And this is also positive for in terms of lung cancer specific survival. And I should say that the statistics are not positive here. We have not crossed the boundary for statistical significance, but I would argue that a 13% improvement in overall survival is unmatched yet in this space, and so very clinically important. And perhaps the lack of statistical significance is firstly that OS was not a primary endpoint in the study design, and that the study was rather small with only 358 patients, so perhaps underpowered to be able to demonstrate a statistical improvement in overall survival. The other thing that I'll note is the early separation of the curves in Checkmate 816, which is unique amongst the other trials, where we see rapid separation as of about 18 months from the point of randomization. These are the overall survival data from the AGN trial, where we don't see that early separation, but with a lot of censoring around 2 to 3 years out from randomization, it does look like these data are going to continue to mature in favor of perioperative durvalumab. The hazard ratio sort of trending on the side of immunotherapy at 0.89, and the lung cancer specific survival clearly being in favor of the patients who got perioperative durvalumab with hazard ratio of 0.7. But I do think that this is a study that still has a lot of maturing to do before we can really make an official call about the benefit on the OS front. The Pembro trial, or Keynote 671, as I said, just recently published. Dr. Garacino presented some of the quality of life data, and I presented the overall survival data at ESMO last year. We have 36 months of median follow-up, and the overall survival estimates are 71% in favor of Pembro versus 64% in the placebo group. And this is the first time in 30 years that a neoadjuvant trial has demonstrated overall survival benefit. So it's a major landmark in this space, and unquestionably validates the use of immunotherapy in patients with resectable stage 2 and 3 non-small cell lung cancer. Now, how does this fit with quality of life? Well, I didn't mention it, but in Keynote 671, there was no impact on the quality of life, no detriment by the receipt of the full course of neo and adjuvant pembrolizumab as compared to placebo administration. But for the surgeons in the audience, we have interesting data from Checkmate 816 showing the evolution of quality of life metrics from the time of randomization all the way throughout the survival follow-up. Remember, 816 did not offer any adjuvant therapy. We classically see a decline in quality of life immediately after surgery, so within the first month or so after surgery, and this has been validated by other surgical data. But interestingly, whether the patient had a thoracotomy or a minimally invasive operation, all the patients, regardless of whether they got chemo or chemo-nivolumab, all returned to baseline by their first scheduled follow-up visit, which is about 3 months out from surgery. And this is very encouraging to us in the sense that if you do have to do a thoracotomy to perform a safe and complete resection, you should do it because the patients will return to their baseline quality of life within a normal amount of time, as has previously been shown by surgical studies. So we shouldn't feel overly compelled to perform minimally invasive operations if in our own hands that's not safe, or if we feel that the disease requires more invasive approach. What about the lobectomy versus pneumonectomy data? Granted, these are smaller numbers, but in patients who are fit for pneumonectomy, the return to a baseline quality of life is rapid and durable. And so, again, based on the need for lobectomy or pneumonectomy, if the patient is physiologically fit to receive such an operation, it should be considered because the return to quality of life is quite swift. And I think these are really important data for your tumor boards when you're debating between concurrent chemoradiation and surgery, because there are no such data from the concurrent chemoradiation world. All the quality of data that we have from patients who've gotten concurrent chemoradiation, at least in phase 3 trials, emerges from the point of randomization after all the patients who couldn't get through the chemorads or who had toxicities were excluded, and only after they've been randomized to either placebo or consolidation durvalumab. Whereas these data take patients from the point of diagnosis. And so I think it's worth noting that the receipt of neoadjuvant therapy has minimal impact on quality of life. Surgery clearly does, but it recovers within a month to 3 months after the operation. And it would be great to have such data throughout the entire trajectory of care from the concurrent chemoradiation world. And finally, data from the 77T trial, which I think are so far unique in this space, the endpoint being time to definitive deterioration in quality of life. I think this is extremely important. What we see here, it has a ratio of 0.66 in favor of perioperative nivolumab. We are prolonging the maintenance of good quality of life, deferring definitive deterioration quality of life by a significant margin. And this is exactly what our patients want. And we should remember this when we're trying to make these therapeutic allocations. What is resectability? So we produced this with, this was some of my own ideas and then refined with the help of Rami Manochekian, Carol Dingmans, and Henry Park for an ASCO learning session. And this is how I think of it when I have a patient in my clinic or when we're discussing them in multidisciplinary rounds. So first of all, we need to have a careful assessment of what the patient's goals of care are. What do they want for themselves? What is going on in their life? Can surgery be part of that? Is their risk tolerance such that they wouldn't accept the short-term risks offered by surgery? Or do they have long-term risk considerations that are important for them that may be more relevant if they're hesitating between surgery and chemoradiation? What is the surgeon's experience with dealing with the type of disease that is before them? And what is their own risk tolerance? We know very well that some surgeons may be very risk averse, others might be overly risk tolerant. And so we need to be mindful of that, know our own data and what we're capable of doing. We need to fit these sort of personal biases of the patient and the treating surgeon with a formal risk assessment that includes physiologic testing to understand what are the sort of statistical expectations of a good outcome. Then we need to understand what is required from a resectional standpoint to achieve an R0. And is this something that is likely or not to evolve with receipt of appropriate therapy? And this is where a biomarker-guided profile is essential. And although we don't have any perfect biomarkers, we can have some expectations that are more or less likely to be met when the patient receives their treatment. And then with all this, we need to see what is the result of the R0 resection, the baseline physiologic function to achieve a patient who will have good functional reserve, good quality of life after surgery. And then we have to measure all this in comparison to the non-surgical alternatives, which have already been discussed in quite a bit of detail. And everyone has to come to some sort of consensus about what is best for that patient. So a few minutes about the key subgroups. So first, PD-L1 TPS, a bit of a controversial subject. We did a meta-analysis of the data of all the available neoadjuvant perioperative trials. And what's clear is that when your PD-L1 negative group is sufficiently powered, you do have a statistically significant improvement in event-free survival. Now, there is a gradient of benefit with the patients who are PD-L1 negative having less magnitude of benefit than those that are 1 to 49 and less so than the ones who are greater than 50%, but all do derive a benefit. Why is that? Is it that we are having sampling errors in the patients that are PD-L1 negative in a certain proportion? If you were to be able to extirpate their disease and look at the entire specimen, that there would be some PD-L1 staining? Or is it that you can get activity of checkpoint inhibitors even in PD-L1 negative, true PD-L1 negative tumors? I think that is an open question. And clearly there is a need for better biomarkers because many of these patients do not benefit, but there is a component of the PD-L1 negative cohort that do, and that is unquestioned. Now, that's on the EFS endpoint. What is not turned out to be positive is the OS endpoint, where we see a hazard ratio of 0.89. Is this because these data are too immature? So at the time we did the analysis, the data from Nadim, Keynote 671, and Patrick Ford, the median maturity was maybe, or median survival follow-up was maximum 3 years at that point. So do we need to wait longer, 4 or 5 years at least, before we see an overall survival benefit, or will we not see that overall survival benefit? I think time will tell, but it's important to keep an eye out on this. But the PD-L1 positives, clear overall survival benefit, has a ratio of 0.49. There's no doubt these patients benefit from this approach. Stage. Well, some people have debated whether patients with stage 2 should get access to this treatment, and it's clear that they should. And similar to the PD-L1 strata, the magnitude of benefit may be a little less, but at 0.71, there is no better regimen. Not to mention the fact that most of these patients are getting chemo, which has proven benefit in the 5 to 10% range overall survival advantage on its own. And using a neoadjuvant strategy, a greater proportion of the patients will get access to that than if you try and administer it in an adjuvant setting. Percent RVT. This is really a critical metric that all of our centers should be capturing. And I think it's not just about PCR, non-PCR. Percent residual volume of tumor is a very important assay that is expressed on a continuous scale. And the information within that number is quite important. It should not be treated as a binary outcome in terms of pathological response. Why is that? Well, we have data from Checkmate 816 clearly showing that it is a continuous variable with prognostic significance in terms of the event-free survival endpoint. So patients with 0 to 5% have much better survival than those who are in the intermediate range in the 5 to 80%. And those patients with more than 80% residual volume of tumor are destined to either die or recur from their disease. So they need something different than immunotherapy. They might even need something different than surgery. And we need to figure out how to better treat these patients. These are the percent RVT data that Dr. David Jones presented at the World Lung, and I think they corroborate and support the ones that have been already shown from 816, but they give us a little bit extra information about who should probably get perioperative therapy. And so what we see clearly here is that the administration of perioperative pembro shifts the pathological response metrics in favor of more deep pathological responses, where you see nearly 50% of the patients who have less than 30% residual volume of tumor. So you can see the median percent RVT is significantly different, with 52% median percent RVT versus 29% in the Pembro group. So clearly deeper responses are being achieved, and this is probably driving most of the overall survival benefit. You see that percent RVT is functioning very much like the TNM, maybe better. And so patients in these different strata of percent RVT have clearly different EFS, and these are all the patients in the Pembro arm. But what about the information of percent RVT to help us decide whether the patient should get more immunotherapy, more checkpoint inhibition after surgery? Because remember, this is sort of like a landmark analysis where you've taken patients who've gotten neoadjuvant, who've gotten surgery, had a pathological assessment, and are now either getting more Pembro or more placebo after the pathological assessment. The margins for the patients who are under 30% RVT are fairly narrow. They do favor the Pembro arm, but it is hard to know whether these differences are statistically significant or not. They remain underpowered, and they'll be interesting to see as more data emerges from the other trials. The 30 to 60% range, these partial responders, are clearly benefiting with a hazard ratio of 0.65, does not crossing unity. You can see this is quite an important difference in EFS between the two groups. But the group that has hardly any difference is the PD-L1 60% or greater. And this is a lot like the CheckMate 816 data, where we see that those patients with poor response or non-response have very bad outcome. Why do I argue that these patients should not get further post-operative immunotherapy is for the following reason. We know these patients are almost certainly going to recur. If we expose them to a treatment that does not offer any benefit in terms of EFS, we are therefore exposing them to a treatment that clearly has a risk of inducing toxicity that may prevent them from accessing better suited trials on progression. These are patients who have failed the standard of care for metastatic disease. They have failed chemoimmunotherapy, and so they really should be considered for innovative second-line trials or trials post-resection that escalate treatment in the non-PCR design. And so I think that giving these patients more immunotherapy is really creating a scenario where there is no benefit. You're exposing them to a lot of risk and may prevent a more useful treatment down the road. So we should be very mindful of that. What about the PCR patients? Should they get more post-operative therapy? Well, I don't think so. The overall survival in CheckMate 816, where there was no adjuvant component, was 95%. How do you expect to do better than that? Maybe the EFS is a little bit lower. Maybe there are 1 in 10 patients who will have an event in the next 4 or 5 years after resection from a PCR, but they're easily and well treated with whatever immunotherapy is given upon progression. And I think we should be very cautious about causing more toxicity, because 1 or 2 grade 5 events due to unnecessary adjuvant in this cohort will mean that we have less good overall survival than we currently already have with a pure neoadjuvant regimen. All right, pathological N2 disease. So this was well covered in the multi-station versus single station debate. I'll summarize by saying that the presence of multi-station disease doesn't seem to, or N2 disease on its own, doesn't seem to impact the pathological response metrics. The EFS seems quite consistent. And what's interesting is that the EFS, and this is true in AGN, it's true in 77T, the stage effects of N2 are seen in the control groups, but not seen in the immunotherapy groups. So you can see N2 versus non-N2 in the control, there is a difference. But if you compare the 2 blue curves, there's really no difference whether there's N2 or not. Surgical outcomes are fairly identical, and N2 has never really been shown to increase the surgical complexity. It's actually N1 disease that increases the response, that increases surgical complexity. But we see that pathological response metrics are the same, whether it's single or multi, excellent pathological response metrics. The radiation oncologist was presenting earlier, was asking why. Well, if there's disease in the lymph nodes where there's supposed to be better interaction between your immune compartment and the cancer cells, you may actually have more induction of memory T cells and better responsiveness. So I think that's why we see good response in N2 positive patients. The EFS, again, the stage effect is clear. Control arms, big stage effects in non-N2 versus N2. No stage effects in patients who get immunotherapy. And that's because likely these patients' micrometastatic disease is being handled in a large part. Single versus multi should not really be part of the discussion of resectability. If you think that those lymph nodes, whether multi or single, are well circumscribed and can be extirpated surgically, then they should be considered, and the patient is eligible for surgery, then it's part of resectable disease. I'm gonna maybe skip over the ctDNA dynamics and leave it for questions because I'm coming up to time. This neoadjuvant versus peri-op, I think you've already heard my perspective on this. There has been individual patient analysis. I think it's quite weak in terms of the way it was structured. Explain quickly why. They tried to compare 816 to 77T patients to isolate the contribution of the adjuvant component. But unfortunately, their finding was that peri-op was better than neoadjuvant. And saying that this was most notable in the PD-L1 negative patients and in the non-PCR patients. Is that the end of the story? Well, there's some major methodological problems. And the key problem is that when they looked at the 77T cohort, there were about 20% who could not make it to adjuvant. And because they were trying to isolate the adjuvant component, they conveniently excluded those patients from the analysis and only looked at those who got adjuvant. But if you compare the two blue curves, the patients who didn't get adjuvant have much worse outcome. Is it because they didn't get adjuvant, or is it because these patients have comorbidities that precluded the receipt of adjuvant therapy? But regardless, it ends up making this an unfair comparison to 816, where they took all the patients who made to surgery. Presumably in 816, there is a certain percentage, probably about 20%, who are poor performance after surgery, who wouldn't be able to tolerate adjuvant. But those patients were not excluded. And so you're creating this very unfair comparison between the two cohorts. It's not an intent to treat analysis. And I think in that regard, this approach has not definitively convinced me of the benefits of peri-op, and this remains to be determined. In the last minute or two, these are our real-world data from Montreal. So between two centers, we had about 250 patients who had received some form of neoadjuvant therapy in the last few years. We excluded all our patients in trials, patients who had oligometastatic disease, and it left us with about 75 patients with stage 2 to 3 resectable non-small cell lung cancer who were treated on standard of care neoadjuvant therapy. The key features of these cohorts: it's about 3/4 of the patients who are stage 3, high rates of KRAS mutation because of, I guess, a Caucasian heavy smoking population. So 35% KRAS mutation. We had a lot of extended resections. Over 40% of the resections were extended resections. 85% of these were completed by a minimally invasive approach. Our conversion rate was 12.7%. Again, with mostly stage 3 patients. And a lot of cases like vertebrectomies, bronchoplasties, pulmonary artery angioplasty. So I think those are reasonable numbers in terms of minimally invasive resection. These are PCR, MPR, non-MPR by PD-L1 levels. So very consistent with what's been seen in the trials. Lymph node downstaging. So I think someone mentioned about, surprised that we consider chemo or chemoimmunotherapy for N2 disease. Well, 73% of patients are downstage to N0. So nodal downstaging is very, very frequent. And persistent N2 was only 14.9% in our cohort. Heavy rates of tumoral downstaging as well. These are the survival outcomes for overall survival. They are looking a lot like the ones we've seen in the trials, and these are segregated by PCR and non-PCR. So with that, I'll stop, and happy to take questions, or if you want to go on to the cases, we can do that as well.
Thank you, Dr. Spicer. Oh, that was an excellent overview about the whole neoadjuvant space. And I think we can quickly open it. We know for a couple of questions. I think Dr. Amish has some questions. Amish, you can go ahead.
Thank you, Amit. Dr. Jonathan, we all make slides every day, but your slides were so amazing. Sometimes I wonder we should take some tutorial from you of making the PPT slides. Really enjoyed. Thank you so much. My question is, we have a meta-analysis earlier of neoadjuvant versus adjuvant chemotherapy. Similarly, can you extrapolate, checkmate 816 to IM010, because one has a 4-year of follow-up, one has a 5-year of follow-up. I think that would be the key answer, because, perioperative like you, I don't think any one of us is, conclusively accepting the perioperative, because we still don't have the data. But it would be interesting if you upfront do the surgery of those who are resectable and just offer adjuvant IO in PD-L1 more than 1%, or maybe all comers, versus give 3 doses of neoadjuvant, nivolumab, and be done with it.
Yeah, so there's, just in the way you phrased that question, I think I'm in agreement with you. The cost effectiveness of 816 is hard to beat. The big problem with trying to do a meta-analysis of the neoadjuvant or perioperative studies versus adjuvant is that the neoadjuvant and perioperative studies take all the patients that we see in the clinic that are diagnosed with stage 2 or 3 lung cancer. They all go in, and whatever happens, happens. When you take an adjuvant study, first you take the patients who survive the operation. So we know there's about a 2 to 3% mortality rate, maybe higher depending on the case, that will die. Then you have the patients who have R+ resections, who are usually not allowed to enter into the adjuvant space. So that's another 5 to 10% that fall by the wayside. And then you have to get, for most of the trials, you had to get chemo. We know that at best, in the real world, it's 50 to 60% of patients who will agree to go to the first cycle of chemo. So you've lost another 30 to 40% of patients before you get to the point of actually being able to randomize a patient. And all those patients that you've excluded are the worst performing patients.
Correct.
And so it's impossible to do a fair meta-analysis that compares the two, unfortunately. And I think it's important to have adjuvant options for patients, because inevitably we operate on patients for various reasons. We have surprise upstaging. Sometimes we have to operate on them, and they need options. But at face value, it's clear that, to me, that the neoadjuvant strategy is favorable, because despite all of those negative prognostic patients that are included, we end up with overall survival outcomes that are very close to the adjuvant studies, which have selected the best performing patients in the surgical space.
Very, very valid answer. Amit, can I just ask him one more question? Sorry.
Yeah, sure. The last question. Okay.
Last question. Dr. Jonathan, you talked about percentage RVT, and that slide was very interesting, where you had a residual volume of the tumor more than 50 to 75%, and you said it's useless or futile to give further immunotherapy because they all are going to relapse. On the other side, checkmate 816, we have such a nice, even with chemotherapy, patients who have achieved PAT-CR have not relapsed.
Yes.
So it shouldn't be, rather than a surrogate endpoint, I think percentage RVT and PAT-CR should be the primary endpoint of all the trials, if we are so confident of these results.
Yeah, so it's we'll certainly be able to accelerate approvals if we do that. I think the FDA is heading in that direction. There was a Journal of Thoracic Oncology paper that came out in the spring that validated the correlation between PCR and event-free survival, but did not validate the correlation with overall survival. And that might be what's holding people back. So, and I think for that, we need more mature and more abundant overall survival data. It's really just AGN 671 and 816 that have reported their overall survival data. And as I mentioned, the median follow-up is somewhere between 2 and 4 years. But if 77T and Rationale 315 and all these other large phase 3 trials start to put out their overall survival data, I'm very confident that the PCR rate, or the presence of PCR will very closely align with overall survival. And the last thing I'll add, I mean, many oncologists in the audience, if you look at the 5-year survival from the metastatic trials using immunotherapy, those numbers are very close to the PCR rates. Now, I think that the patients who have metastatic disease who are alive at 5 years are the same patients who are getting PCRs. And we'll have to be interesting to look at that one day to make that comparison. But I think that's what's happening.
Basically. They are the better biology patients.
Correct. Yeah.
Great. Actually, that's a very interesting point which you made, that 25% doing well in long term. Excellent. Okay. I think what we'll quickly do is we just have a few cases.
Dr. Amit,
Yes.
Hi, Virendra here. I just wanted to ask one small doubt to Dr. Spicer, if you allow.
Okay, quick. Yes.
Hi, Dr. Spicer, Virendra here. So one doubt I had, we have lot of, now data regarding perioperative, neoadjuvant, adjuvant, everything that we have discussed so far. So what is your opinion? Do we have, any role of circulating tumor DNA to decide whether the patient should be continued on adjuvant chemotherapy or not when he has received a neoadjuvant?
It's a good question. So I don't think those data are can be used yet for decision making. What's clear from the AGN data is patients who have persistent ctDNA after completion of neoadjuvant, or especially after surgery, are very poor prognostic patients. But it's not clear that those patients do better because they get immunotherapy. So we need to we have to figure out how to make decisional trials based on ctDNA, because they clearly very indicative of a poor prognosis, but figure out how to match that data with treatments that are actually going to have an impact. Because if we say randomized patient with persistent ctDNA to more checkpoint, I'm not sure that that's going to be the answer. They probably need a biologically suited regimen that will actually cause a response. And I think that's when we're going to be able to use ctDNA in the clinic more in a useful fashion, is when we have trials that are using this as a decisional metric. And at some point, we'll have to make that leap.
Thank you.
Okay, I think let's get to the last session. These are going to be some quick case discussions, and for the discussion, we will have expert panelists with Dr. Spicer and Dr. Amish Vora, and also Dr. Manish, Dr. Bhushan, and Dr. Sajjan will also be panelists for this cases. So let's start with the first case, where Dr. Arvind Krishnamurthy, who is from Chennai, will start off with the first case.
Yeah, I think I'll share my screen. Just a second. Yeah, I think yeah, I think thank you for the opportunity. Really enjoyed Professor Spicer's talk. It's really full of data, and read some of his publications as well. And I was told to present a patient who was a stage 2 non-small cell lung cancer. So in the interest of time, I'll quickly run through the case, and so that we can have some points for discussion. This was a 53-year-old lady, fit lady, PS1, never smoker, just some mild cough, evaluated with a chest CT. Subsequently, a lung mass she presented to us. We did a PET CT. It showed a 6.5 to 5.8 into 4.6 centimeters left lower lobe lung mass, just invading the parietal pleura. Absolutely no uptake in the mediastinal nodes, and no uptake elsewhere in the body. And very quickly, we did a biopsy, adenocarcinoma grade 2, driver mutation negative, PD-L1 5%. EBUS was negative, MRI brain was okay, extremely fit. So this is a young, a 50-ish lady who is very fit. PFTs are fine. Customer left lower lobe of lung, CT3, N0, M0, stage 2B, driver mutation negative. And these were the, in fact, this is a patient who is with us. So just wanted to sort of, get the management options. Yeah. then maybe I have some perspectives and some opinion. I can share it later.
So, Dr. Bhushan, if this comes to you, what are your thoughts on this, or your comments?
Yeah, EBUS is negative, and T3 the size criteria.
Yeah.
Patient is fit, so I will go for and it is a lobectomy, so I will go for upfront surgery in this case.
Okay, Dr. Bhushan is for upfront surgery. Dr. Sajan, your thoughts on this kind of situation? Okay.
I think the basic premise in this case was, I think, because it's a stage 2, and normally that we find, at least in the trials, that stage 3 onwards, you have incremental benefit of perioperative chemo and immuno. But of course, you had the meta-analysis, which Dr. Spicer was also a part of, which was published at the JAMA earlier this year, that showed some benefit in stage 2 as well. But then the thing was that apart from the Keynote 671 trial, majority of the other trials, you had the event-free survival, the hazards crossing unity. So, and even in the ISLC consensus document, I think it was not a major consensus. There was a lot of differences of opinion also, essentially. So that was the thing, whether the meta-analysis should be taken as the final word, and should chemoimmuno be considered as the preferred approach, or do a subset of patients would benefit from upfront surgery. And this was the large discussion that we were having in the MDT, and I would like to clarify. I would want everybody, Professor Spicer or everybody else, to clarify.
Dr. Spicer, your thoughts on this?
Yeah, so I think this is an area of some equipoise for a lot of people. In our center, there's no doubt this patient would get neoadjuvant chemoimmunotherapy and surgery. The reasons we do that are the following. This is almost T4, by the way. I mean, it's pretty close to a T4 tumor. It's a big cancer. We know that in these patients, chemo on its own has an overall survival benefit. And we think that, and the other thing I didn't mention is that our rate of non-resection in patients who get neoadjuvant is much lower than what's published in the trials. It is not 20%. If for a patient like this, I can't think of a single patient that we've treated with neoadjuvant therapy with T3 and 0 that has not gone to surgery. So our fear of not operating on this patient is very low, because we've developed sort of experience with giving neoadjuvant therapy. And even in the era before immunotherapy, this patient in our hands would have gotten neoadjuvant chemo followed by surgery. The reasons are that there is a 5 to 10% overall survival benefit to getting chemo. And the morbidity of chemo when given before surgery is less than when given after. There's a nice paper from Sloan Kettering where they looked at their patients who got neoadjuvant versus adjuvant chemo, and the grade 3-4 toxicities from chemo on its own were less in the patients who got neoadjuvant therapy, because the patients have not been harmed by the operation yet. And for a tumor this size, even if you do it minimally invasive, you're going to have to make a 6 or 7 centimeter incision to get the thing out. So I think that if you look at the total trajectory of the patient and minimizing morbidity for that patient, giving preoperative therapy really is the way to go. There might be significant tumor downstaging. You might be able to get the thing out through a little 3 or 4 centimeter incision, do a VATS lobe, and you may not need anything further. And you'll have the response assessment, which is quite valuable for the prognostication of that patient and how to surveil them. You know, if they've had a PCR, you can tell them they're as good as cured, you know. So I think for all of those reasons, our choice would be neoadjuvant followed by surgery. Because if there isn't a big EFS difference in the stage 2 patients, it's because the chemo patients got chemo, you know, and if you take them to surgery first, at best, maybe half or 2/3 will get the chemo after the operation. We know that a lot of people will decline or not get to the adjuvant chemo.
Right. Okay. And just to follow it up, you do the neoadjuvant, and in the current timing, if you got the PAT CR, you stop and don't do anything further, or how do you decide on the perioperative part for this patient?
Well, it's an easy decision in Canada because we don't have access to perioperative. So they get checkmate 816 and that's it. But I think when we'll have access, it'll be complicated. It will have to have these sorts of discussions in the absence of data about what to do. And it'll be patient level discussions with the oncologists. And
Yeah, the other thing was with regards to the timing of surgery. Like, I think Bhushan did have a slide on it, and there was some recommendation in your ISLC consensus statement also, maybe a month or so. What is your preferred approach and advice to us, Professor Spicer?
so it's another data-free zone. We don't know. Most of the decisions are based on the return of myeloid function from after chemo. So the way we do things at our hospital is the surgeon sees the patient at the first visit. We determine that it's resectable disease. We usually have a chat with the oncologist that the patient is also eligible to get neoadjuvant therapy. And I consent them and get a booking form for surgery at that time. So now all of my logistics support, the secretaries, all that who do the OR booking are in communication with the oncology team so that after the last cycle, the third cycle of treatment, they know that I need to be informed of the restaging CT to make sure things are still okay, and that the surgery should be booked 4 to 6 weeks after the last cycle of chemo, provided there are no complications that emerge. And so everything from the point I first meet the patient is now set in on a program. I don't rediscuss the patient tumor board. I don't book them after completion of neoadjuvant therapy, because then our surgical delays enter into play, and it might be 2 months before I get them to the operating room, and I think that's not ideal. So we try and do things in a programmatic way, established from the first visit that this is how the plan, and try and execute that plan.
Right. Okay.
Thank you.
But there are no data, right? There are no data telling us that it'd be better to go earlier or to go later. The only data I know of that make me a bit concerned about going too soon are the LCMC3 data, where patients had to be operated within 2 weeks of the last dose of atezolizumab, and it was a IO monotherapy trial, and they actually saw more immune-related adverse events after surgery than they saw after neoadjuvant. So I kind of like to things to cool down a little bit with that month to 6 weeks, so that maybe there's less post-operative IO issues that emerge.
Yeah. Dr. Bhushan, you have a comment?
Yeah, I would like to ask Jonathan, you have given chemo IO in neoadjuvant setting, and the patient has got myelosuppression. And that myelosuppression, low platelet count, low hemoglobin, it doesn't get corrected. 1.5 months pass away, 2 months pass away. So what is your take? Should we contemplate surgery or go it for further immunotherapy or CTRT or something like that?
Yeah, it's a really good question. It has happened sometimes. These pancytopenias can be a problem. We wait, we take the time. We're usually, because most of these patients have usually had some response. I think if you have no response, or you're really concerned about the fitness of the patient, then maybe you need to switch gears and think about radiation or something like that. But we usually try and be patient and wait it out. Same thing with immune-related adverse events. If they have to go on a course of steroids, so be it. And we take the time it takes for them to be fit for the operating room. And we might repeat more staging scans, to make sure we're not watching progressive disease. But I've not experienced that, to be honest. The patients who've had immune-related complications, or even the pancytopenia, they can be a bit rocky in the OR, but in the post-operative course, but they don't usually have progressive disease. It's not what we've seen.
Right. Okay, great. I think we'll move to the next case quickly. Dr. Virendra Kumar, please take over for your case.
Yeah, thank you. I'll just share my screen. Sorry. Is it visible?
Yes,
Yes.
yes.
Thank you. So this is a case that we recently encountered in our hospital, and this is the flow that we have followed. And I would just like to have opinion of the rest of panelists whether that is okay, or is there any other management option for such a case. So it's a 44-year-old male presented with cough with good performance status, ECOG 1, effort tolerance of 3 floor, no significant comorbidity. He came with a CCT done outside, and there was a right lower lobe mass solid lesion. We did a biopsy here that turned out to be adenocarcinoma. TTF1 was positive, and he underwent metastatic workup with PET, CCT, and MRI. Next slide, please. Next. Yeah, so this is a medicinal window, and you can see right lower lobe lesion with a low volume, 4R and a 7 node. So as per PET, it was clinical T2 and 2, a central lesion. Next. Again, same thing, lung window, no other site of disease except right lower lobe lesion. Next slide. Next, MRI brain was non-metastatic. Fusion images had a small volume, subcarinal and 4R node. So we did the EBUS, and on EBUS we found that 4R and 7, both stations were positive for metastatic disease. We planned for neoadjuvant chemo IO. The plan was to give 3 cycles of chemo plus IO, but because of some monetary issue, we started with chemotherapy, and after second dose of chemotherapy, second cycle of chemotherapy, patient was willing for immuno, and then it was added. So total 4 cycles of chemotherapy with 2 doses of nivolumab he received. Response PET CCT was done after this. Next slide. Next. There was a partial response at the primary, and nodes also reduced in size. Next. Same was seen in lung window also. Next. After this PET CCT, we did a functional workup, and his PFTs were good. 6-minute walk test was also fine. 2D echo was fine. So what we planned for this case was VATS right lower lobectomy with systematic mediastinal lymph node dissection. So now only thing is point of discussion in this case is that earlier before these immunotherapy trials, our concept was that multi-station N2 is a treatment for CTRT, but now there is a paradigm shift, and these subset of patients are also being included in a surgical aspect. So I would like other panelist opinion whether that is okay, or should there be any other management.
So, okay, I think Amish, your thoughts on this case and how would you take this forward?
I think they have achieved partial response, though the PET CT to me look like 20 to 30% response at the best, the before and after, what we say. I think surgery, if it is feasible, we should go ahead and do the surgery. Wait for less likely to be pathological CR from the PET CT looks like. I think this is the case where perioperative IO, whether it will work, if there is ctDNA, because it's from TMH, if you are doing some study on ctDNA, and if there is a much less ctDNA, I think I would continue with adjuvant immunotherapy in this particular case.
Amish, Virendra also wanted to know, would you take him for CTRT directly without doing the neoadjuvant approach, considering the N2 node?
See, unfortunately, during the debate also, I wanted to ask that question, but if you see the Pacific data at 5 years, the number of patients alive versus in the perioperative IO or in Checkmate 816 at 4 years. I think the data with perioperative or neoadjuvant IO plus chemo is better than CTRT. I would like to convert these patients into surgical candidates if it is possible. CTRT is always there.
Right. I think all of us are thinking about in this direction. Dr. Spicer, what are your thoughts on that decision?
Yeah, so looking at, they were nice. It's a nice case and good imaging pre-op. I think that I would have agreed with you that this was amenable to resection. You know, the lymph nodes weren't coalescing and circumscribing the airway or the PA, creating a scenario where they couldn't be resected. So it was, in my mind, resectable regardless of the multiplicity of N2. And so we probably would have adopted a similar treatment plan as you did. There's two points I think are worth mentioning. One is when we did the JTO, the ISLC consensus, we've had to respond to a letter to us sort of criticizing our position on the restaging. So two things. We didn't mandate PET CT because we knew that around the world, not everyone would have access to it, and that it might not change the management for now anyways, for most patients. I think it's a fine thing to do, but it's sometimes difficult to interpret to know whether the SUV response really means that there's no disease left or not, and what about flare? And so to simplify things, we said it's not a necessary part, but it could be a useful adjunct. And then the thing that came up in this response, in this letter to the editor, was on the necessity or value of invasive restaging. Should you redo an EBUS or a mediastinoscopy after completion of neoadjuvant, especially in N2 disease, to determine whether there's utility of surgery or not? My perspective is that local consolidation by surgery is probably just as good, if not better, than chemo RT, and probably just as safe in a fit patient. So whether there's necessity to operate or not, in my mind is we don't know, but it's a relatively safe thing to offer them a surgery. You offer them a right lower lobectomy node dissection. I think that's an acceptable thing. And so whether or not there's persistent N2, if the disease is still resectable after induction, I think we should resect. Because what else are we going to do? You know, now the counterpoint to that is I used to say, well, yes, concurrent chemorads is always on the table, and it often is, but the Pacific 2 data may give us a bit of pause, and the additional data coming through about concurrent IO with chemorads not showing any benefit, in fact, showing some toxicity, makes us think about the dangers of not assessing resectability up front. So if you start giving induction chemoimmunotherapy to a bunch of patients who aren't really resectable or too close to the borderline, you may be creating a scenario where the administration of concurrent chemo RT is now more toxic. It may turn out that we have studies that give induction chemoimmunotherapy followed by concurrent RT or definitive RT that are just as good, if not better, than traditional Pacific, but we don't yet have those data. So we do need to be a little bit cautious, I think, about including excessively advanced disease that's not amenable to surgery in the hopes that they might downstage. We have to be cautious with that. I think it's a great path forward. I'm a surgeon. I like the idea, but we do need to be a bit mindful of the risks.
Amit, just add on to the thing. One thing which, I know, Jonathan, you are a thoracic surgeon, but, in terms of the selection of the platinum, Asian study said cisplatin is superior to carboplatin, while Checkmate 816 put forward carboplatin plus IO, and where it is up to 80% 4-year OS. I think there's a first study where carboplatin was found to be better than cisplatin, but on the other side, Asian was not so better. Anybody, Amit Rautan also, you can take this question. I'm still surprised and wondered, in a fit patient, should we select cisplatin or carboplatin? I know it's an age-old question, but still.
So I think we've been stuck to cisplatin a long time in lung, and we keep thinking, no, that's the best. But I was happy with this because we do a lot of carboplatin in lungs. I admit it. And I can tell you in the last few years of doing neoadjuvant with carbo, chemo, IO, we've hit PAT-CRs equally well in many patients. And I don't think we are doing anything inferior. So I am good with carboplatin. I don't insist for cisplatin at all, except when you have those young fit patients where you just want to do it, That's my take on it.
Absolutely, I agree. And Dr. Virendra, Dr. Jonathan, and Dr. Arvind, is it the guidelines say if your PET CT is mediastinum negative, you do not require path proof. Is that what you people follow in your respective institutes? I would really like to know, because I always get stuck on whether should you do sampling or pathological N1, N2, N3.
I'll just jump in.
Yeah.
I think it's quite important to stage accurately, so we follow the guidelines for central lesions or tumors greater than 3 centimeters. We advise invasive staging.
So, Dr. Amish Virendra here. So, in our institute also, only patients whom we not do invasive mediastinal staging is clinical T1 and PET N0. Another thing is that especially for adenocarcinoma, the avidity of mediastinal node may not be that significant. So even if there are morphologically positive nodes, it is better to sample those nodes, especially in adenocarcinoma. And second thing is that we have looked into our subset of patients. We have lot of granulomatous disease. So even on PET, you may find a bulky node, big node, but most of the time they are because of some previous pre-existing or granulomatous disease. So in our series, the positive predictive value of PET was only 50%. So I think if you are planning for any curative or surgical intent treatment, it is better to stage mediastinum with either EBUS or mediastinoscopy. EBUS obviously preferred.
Great. I think quickly, because we're running short of time, last case, I think, let me go to
Amit,
Dr.
sorry, Dr.
Kshitij.
Amit, one doubt, one question I want to ask to Spicer, if you, really short one.
Okay.
So in most of the trials, we have seen that surgical problems are not that much with neoadjuvant immuno. But to Dr. Spicer, I want to ask, suppose there is an interlobar node sitting on a PA and you could not sample that with EBUS, and that has responded post your neoadjuvant. So how difficult is it to tackle or remove those nodes? What is your, a real world problem?
Yeah. So there's a nice study from MD Anderson showing that the surgical complexity increases significantly when you have large N1 nodes that respond really well. This was true with chemo. It's definitely true with the addition of immunotherapy. Those are the patients where we need to do proximal control on the PA, where we may need to do bronchoplasties, PA plasties, angioplasties, sleeves, etc. And it's because we lose the plane between the artery and the bronchus, which is usually nice and easy to encircle to do your lobectomy. So I think you need to be prepared for a more complex operation and a higher likelihood of conversion for those patients, because they can be very, very challenging. I don't know if this is specifically your question, but I have had a couple patients who had lower lobe tumors. And you can only get so much of the N1 disease. You may have some N1 lymph nodes that are in the hilum of the right upper lobe, and you're not going to go do an upper lobectomy for a lower lobe tumor that might have a lymph node there. And so you do your best to clean off the PA, but I think at some point there are some lymph nodes that you just can't quite access. And I have had one patient have a level 11 recurrence, isolated recurrence a year or two later, who had a positive residual disease in the level 10 lymph node. And I guess so that level 11 in the hilum of the upper lobe was an in-transit lymph node that had positivity, but that wasn't accessible surgically.
So are you facing such problems more with immuno compared to what it was with chemo alone, or it is almost the same?
I don't think it's any different from before, to be honest. But maybe because the depth of response is greater, you may encounter even more fibrosis. Yeah. So that I think those are the most difficult surgical cases, without a doubt.
Thank you.
Great, great. I think we'll quickly go to the last case. We're running short of time. We have Dr. Kshitij Damodia, who will present his last case. Over to you, Dr. Kshitij.
Yeah, thank you, organizers, for giving me this wonderful opportunity, Dr. Jonathan. It was a great treat to hear you. So I quickly share my screen. Okay, so I quickly run through the case. So this is a case of a 62-year-old male smoker, and he was evaluated for cough and right-sided chest pain for 2 months duration. I jumped to the PET CT findings, and these were the findings. It was a 50 by 35 by 30 mm SUV of 9.2. FDGI with pleural-based mass lesion in anterior aspect of apical segment of right upper lobe, with marginally bulging into the adjacent lateral aspect of first intercostal space without knee reporation or mediastinal infiltration. There were subcentimetric FDG avid lymph nodes at bilateral supraclav, right upper and lower paratracheal, subcarinal, right hilar, and subaortic regions. Possibility of metastatic nodes, the largest was at the right lower paratracheal of 19 by 12 mm in dimension. So the biopsy was non-small cell adenocarcinoma. And he was already started on pemetrexed and carboplatin from one of the oncologists, and then patient came for a second opinion. So that was the thing. His NGS didn't show any driver mutation, and PDL1 was TPS of 70%. It was quite a high PDL1 expression. Now, the question which we had is the patient has already received 1 cycle of chemotherapy from outside, and he had a very significant improvement in his clinical symptoms. So, any point in doing a mediastinal staging now?
Dr.
Tricky
Spicer.
situation.
Right.
Yeah.
Yes. N3
Because
node.
it looks like it could be N3, right? It's
Right.
this is a tough situation. I think if you're fairly convinced that that the PET signal is true. I mean, I don't know what it's like to practice in India. I know there's a lot of tuberculosis, granulomatous disease, and other things that can explain these findings. So because it could also just be a stage 1 tumor and unlikely to have sterilization with 1 cycle of chemo. So I think just to assign the best possible treatment for this patient and rule out N3 disease, it makes sense to attempt an EBUS. It's a low morbidity thing to know, have more accurate information.
Right. So what was done actually was he was started he was continued on the chemotherapy. It was decided to add immunotherapy to that, and a mediastinal staging was not done post 1 cycle. Post 2, he had a stable disease. He continued with 2 more cycles of chemotherapy with pembrolizumab, and this is the end of treatment PET scan, and that showed a partial response in primary. Both the mediastinal nodes as well as the supraclavicular lymph nodes had a very good response. So at this moment, the mediastinal staging was done, and all N1, N2, N3 were negative for any malignant cells. So now we were actually stuck on what to do further for this patient. So I would like to have an opinion on panel as well as Dr. Jonathan for this.
I think you've done the right thing.
Right.
I think you've proven that the patient had N3 disease, but with the PET response to treatment.
Right.
N3 disease is oligometastatic disease in my view, and so maximizing systemic therapy makes sense. I know I said that we don't want to induce patients who could be treated with chemo RT, but on the flip side, those patients are almost all micrometastatic, so it does conceptually make sense to me to give them optimal systemic therapy and then consolidate by whatever means are best, the same way we do for most oligometastatic disease. So now the question is, are you going to operate or are you going to radiate?
Absolutely. Yeah.
Yeah.
Kshitij,
think-
Amit here.
Yes, sir.
Assuming it was N3 to begin with, would you ever plan this patient for surgery? I think
So-
you have done the right thing. You have done the mediastinal staging, but upfront, when the patient came to you and MDT was discussed, why
Right.
was it not decided to do mediastinal sampling at that point of time?
Right. So the fact was it was conveyed to the patient, but he actually refused for that. So that was the thing. I know doing an EBUS at that time would definitely add to the value, but somehow it was not done. It was done at the end of treatment, and now actually we were stuck. What to do? So I think that brings us to a thing that an important staging, mediastinal staging is must prior to any sort of treatment. But after this, after a good response, now the mediastinal staging is negative. What should one do? Surgery, radiation, or just continue the systemic treatment? He has already received immunotherapy as well. So any tricks on doing a definitive chemo radiation post induction chemo immunotherapy? You think it adds to toxicities?
I think there's toxicity to that for sure.
Right.
I would be, not that surgery is free of toxicity, but I'd sort of be in favor of offering the patient a resection, dissecting all the lymph nodes. You would have accurate staging. You would know the depth of response, and if, say, you had residual nodal disease. The other thing is, I mean, you did the EBUS, there was no disease, but sometimes we see differently at surgery. And now you have a good response assessment, and you can decide whether to consolidate the mediastinum, which might have more toxicity than just the resection. I don't know. It's a very difficult. You're working in sort of outside of data. It's a tough one, but I'd make a case for offering surgery if the patient's fit.
Yeah. I can add on similar case 2 years back in 2022, I think. So we had this case. The patient was unfit, N3 disease, 10 centimeter mass, and we gave pembrolizumab based therapy, and the tumor disappeared, and it was a ghost completely. And he started having hemoptysis. I had to operate in a salvage setting, and to our surprise, it was major pathological response, 1 mm of tumor found, nodes negative. And now it's almost 2 years, the patient is doing good, no metastatic disease anywhere. So it is probably the customized thing. And the surgery, I will say it's very difficult to contemplate. It was because patient received half therapy somewhere else, received pembrolizumab, and later on half therapy somewhere else, and it was in salvage setting. It was totally fibrous. I had to do. I started with robotic, then VATS, then it was ultimately open surgery. Totally adhered everything, but the end result was like a little bit stormy post-operative period, and end result is like patient is driving a bicycle now.
Great. I think these are all wonderful cases where we have to take individual decisions, and it's great when we get these great long-term results. I think it's been a wonderful session. We have really short our time. I thank Dr. Spicer for his wonderful talk and the lovely discussions, all the question answers. And I'd like to thank all the panelists for their lovely cases and all their discussion comments. Over to this, I think I will conclude, and over to Dr. Kirtana. Thank you.
I'm going to sign off, but thank you very much for the invitation. It was nice to chat with all of you.
Thank you so much, sir.
Thank you.
Thanks a lot. And I'd like to extend my very heartfelt thanks to all of you for being part of this wonderful session and taking your time off on a Saturday evening. And it was a very enticing and a very insightful session. Thank you, Dr. Ahmed Rathan, sir, for moderating it. And thanks to all the wonderful experts who've been part of all the sessions today. And a wonderful thanks to Dr. Jonathan Spicer, sir, as well. Thank you, team. Thanks, everybody.
Thank you. Bye.
Yeah, bye.